Well, here we are at the Future of Hearing Healthcare meeting. And our task as a panel today, a panel of industry people, clinicians, and consumers, our task today is to discuss the hearing loss and stigma issue and try to break down some barriers to care. And uh, First thing I'd like to do is to have my colleagues on the panel introduce themselves. And Bill, would you introduce yourself?
Absolutely. Hello, everybody. I am Bill Shipman, founder of Acoyo. Acoyo is a consultancy on accessibility and auditory health management. I am a lifelong hearing aid user, and I am former lead of accessibility initiative at Apple.
Great. Tony, would you introduce yourself?
Thanks, Bob. Hello, everyone. My name is Tony Solsona. I am the director of the audiology channel for Nuance Audio. In other words, the Nuance Audio OTC hearing classes.
And Michelle who?
Hey there. I'm Michelle Webke. I'm an audiologist, and I'm joining today as the Senior Lyric Audiology and Education Manager at Phonak.
Great. Andy?
Thanks, Bob. Andy Bellavia, and I was formerly responsible for marketing and business development at the hearing health tech company Knowles. And then 3 years ago, I split off to form my own consultancy. And I guess I cover 2 out of 3 because I've been now 7 years a hearing aid wearer as well.
Sherry?
Hi, everyone. I'm Sherry Eberts, and I am the founder of livingwithhearingloss.com, as well as the co-author of Here and Beyond, Live Skillfully with Hearing Loss. And I have been wearing hearing devices since my mid-20s.
Okay. And second, Michelle.
My name is Michelle Hu. I have been a pediatric audiologist for over 16 years now. I'm a bilateral cochlear implant user, and I'm founder of mamawhohears.com, or also on Instagram, where I help support hearing parents of deaf children navigate the journey.
Fabulous. So as you can see, we have a great group of colleagues here that are going to help us navigate through the issue of stigma. And it remains one of the most persistent barriers to hearing health care, shaping how people interpret hearing loss. It delays help seeking and limits adoption of hearing technology. Hopefully this panel now can begin to address those issues. And I think I'll just start a little bit with, when I had my practice back in the 70s, early on, people would have to be about 95 years old and have about 60 decibel hearing loss before they would even consider walking in the door. Just in general, how do you see, as a group, how do you see that maybe that has changed somewhat in the new century, and particularly in 2025, relative to, say, 1975?
Okay, I'll take this one. I think definitely COVID played a good part in this. Maybe not, it was very difficult in the beginning with the introduction of masks. It became very difficult for us deaf and hard of hearing people to communicate, to feel comfortable, especially in doctor's appointments, when our healthcare providers were covering up their mouth and their facial their half of their face so that we couldn't get those visual cues to communicate. That was our superpower, and that was stolen out from under the rug from. So stigma, I think, is very much an external societal type of pressure or creation of story where, denial is something very much more internal. What kind of stories are we making about either ourselves or what society is thinking about us? And stigma just adds fuel to that fire. I think that because we are much more expressive and emotionally intelligent, or like we built upon that realization and opening our awareness, it's become less and less because we're communicating with each other. We're building a deaf and hard of hearing community so that we can support each other. And I don't think we had that before. It was very much behind closed doors, your business is your business. And now it's like, you know what, let's share, let's grow together, let's grow stronger. I think that's part of melting it away a little bit.
Great. Some other comments on that one statement about how maybe things have evolved to some degree over the years?
I think that's probably the key benefit for OTC, even though we all know right now OTC has not really fulfilled its promise. It's barely making a dent in a number of people seeking hearing care of one kind or another. But on the other hand, there were a tremendous number of positive messages in the popular press surrounding the release of OTC and then subsequently like Apple's entry and Luxottica's entries, for example. But really a ton of mainstream press coverage on the importance of hearing care and what OTC is meant to address, which even if people didn't go for an OTC, they were hearing those messages. And I have to believe that that caused a dent in the stigma/denial problem.
Okay. Some other comments? Some other
Yeah,
comments?
so I have a profound hearing loss, so I use prescriptive hearing aid. That's non-negotiable. I do not have any other choice. I need it. And in the years of building our consultancy on auditory matters, no matter how you reframe hearing loss, no matter how much you put a name in terms, people won't address it. What did change, to Michelle's point, with the pandemic where you had the mask, there was a startup called Listen Lively. And Listen Lively suddenly was going after tech-savvy people in their 40s saying, I got power in my hand. I like technology. I like the internet. What can I do to take care of myself? And I think as we were waiting for FDA approval on OTC, Listen Lively, which was acquired by GN, that became Jabra Enhanced, started something. They started to recognize younger cohorts, not the 95-year-olds that you mentioned, Bob, from the 70s, but now for years where the hearing aid manufacturers have been trying to get those outside of the baby boomer generation. It's like, how are we looking at hearing loss? How can we approach it differently? And I think we started to do that. It's not taking off as much as we'd like, but we're starting on to something.
Mm-hmm. I think a lot of audiologists split into two, like anti-OTC and supportive of OTC, because they thought the ones anti thought that OTC would threaten their jobs. I'm in this camp over here. It's another stepping stone to get to if they need prescriptive hearing aids or custom programmed hearing aids. It's a step of, oh, like the readers at CVS by the register. Maybe these will help me. They help me a little bit, but I think I need some more. And that's a stepping stone to get there. And companies like Apple, who are bringing in their AirPods as and marketing them as OTC hearing aids with a hearing test, is a very good step in that direction.
I think part of the issue with OTC, at least initially, was that the first wave of products, I don't know, missed the boat a little bit, right? They looked like typical devices. There wasn't always Bluetooth streaming. It didn't give the consumers necessarily what they were looking for from a device of that type. And I think the media coverage was great, but a lot of it contained some of this outdated imagery, right? So we weren't seeing that modern look, that new look that people with mild to moderate hearing loss were really going to be attracted to. And that perpetuated the stigma a little bit. But like we've all said, I think some of these recent new products with different form factors from big names are going to start to help. But really what I think is going to get these mild to moderate people, who are the target, obviously, for the over-the-counter, over that hump of trying to use that device, is that the devices need to work well. They need to meet their needs in the situations that they're looking for them to use that. And so when we show, I think when these devices show the benefit, that's when the stigma is going to be fading. Because if people can talk about, I actually used this kind of cool thing and it actually helped me in this restaurant, that's when that stigma is really going to start to come down. because people will understand the benefit that they're getting from it.
Sherry, I love the fact that you said cool, because for many, many years, and I've been in the traditional hearing aid space for many, many years as well, and over 22 years in the industry. And I used to always say to colleagues, consumers, et cetera, when will hearing solutions, especially as we approach OTC before it was approved, what will it take? And I used to say the same word. When hearing aids become cool, they become attractive. When they become attractive, they become viral, more adoption. Then you can branch out into innovation, et cetera. And thank goodness, like other wearables, hearing aids are in that early stage of looking at different modalities and shapes and et cetera that create a sense of attraction, or at the very minimum, intrigue, not only from the consumer, but certainly from hearing care professionals.
So while we're at this, let's throw another thing out there. Do you think that there's a real difference between stigma and denial, or does one kind of feed on the other?
Well, I think like Michelle said, they're interrelated. But stigma sometimes comes more externally, and denial, I think, sometimes comes a little bit more internally. Denial also is, I think, part of the nature of the beast, because hearing loss a lot of times comes on gradually, not always, but a lot of times it comes on gradually. And so we may not really know how much we're missing until there's sort of an event or something happens, like the masking in COVID, or like the TV gets to a certain level where everyone just starts complaining about it. So we're kind of in denial because we don't experience, the actual external impact of that hearing loss. But the stigma comes, I think, from the outside. But where it really hurts is when we take that inside ourselves. And I think a lot of people do. And part of that is because of the way it's portrayed still in mainstream media. You wouldn't make fun of somebody on a television show who was blind for bumping into something, but you can make fun of somebody for mishearing something. And until we're really not seeing that, where people with hearing loss don't look foolish, that external stigma is, we're at risk of internalizing that.
Yeah, I agree. And there's a dimension to that too, which is harder to overcome, and that's ageism. In many Western countries, ageism is pretty prevalent, or perceived ageism, if not real ageism. I'll give you one example, the job site Indeed.com. They actually published an article. They were forced to pull it by the outcry, but they published the article which showed stages of one's career. And at 50 or 55, you were in decline. And so I've actually got the graphic because people published it before they pulled it off the air.
Man, I declined a long time ago, Andy.
Yeah, you and me both, right?
I mean, by now. So,
but that sort of thing, those messages are prevalent. And so if you're, say, in your 50s and you're worried about your future career prospects or feeling like you're being left behind in favor of younger people, it may be that the last thing you want to do is show up with hearing aids because of that perception. And so that's a hard barrier to overcome.
Well, just an example of that.
You always go back to your 1970s haircut, guys. And because that'll help a lot. Sorry, Sherry.
Oh, that's okay. I was just saying it is a perfect example that just happened to me the other day, actually, Andy, that speaks to that point exactly. Is that a cousin of mine called and said, I'm a little bit worried. I'm not hearing so well at work, and I'm not hearing so well at these cocktail parties, but like I can't be that guy with hearing aids. So like, what do you got for me? But I can't, because I'm worried how that's going to impact my appearance and my performance at work. So it's a perfect example of what you were just talking about.
Absolutely. And I know I'm jumping issues here, but that's why I really like the alternative form factors like the nuance glasses, because they won't combat stigma. They hide the stigma. But on the other hand, if you're taking, say, a 50-year-old person and getting them hearing care today, that's the most important thing of all, because especially in the workplace, if you don't treat your hearing care, you look like that out of touch old guy because you're missing things, hearing things improperly, and so on. And so that's an important part of the equation, even though it doesn't address stigma, it hides it. It does get people's care earlier. And then as a stepping stone, which was said before by a couple of people, once they're in that sort of thing and they get comfortable, if they need to go beyond what they can get out of the glasses or earbuds, then they may be more amenable to getting a better prescriptive solution.
And
Yeah,
Andy,
I
and
think that's a really all at once.
No, go ahead.
I think it's a really great point you just made there, especially with that it doesn't combat the stigma. I mean, we definitely have a lot of patients who wear Lyric who really want it for its invisibility. And that's why they come to Lyric, but they end up telling a lot of people about it after they're fit because they love how they're hearing. And so I think if we look at it as these form factors aren't helping push the stigma forward, I think we have to reshape that ourselves because it is pushing it forward because they are getting help maybe earlier, or maybe whether it's the stigma or denial, whatever it is, if we don't have a solution that fits whatever they want, then maybe they go without a solution, which is not helping any of us. So it does move everything forward, I think, by having these other options and certainly giving these interesting ways to treat something. And especially as I think the entire field even advances in looking at hidden hearing losses and some of the things that are happening even in the lower spectrum of the hearing loss scale as well.
and
I
to
love
your,
everything you said.
yeah.
and
Tony,
to
you,
both of your
Sorry,
points,
guys, go ahead. Let's
to
see,
both
Bill,
your points, just
Tony?
a quick,
Yeah.
for Andrew, Michelle, to your point on that, two things. One is whether it's masking it or hiding it, the fact that you can put on or wear a solution that you have confidence in, to the extent that you're even willing to showcase it to someone, means that you are sort of promoting the solution and not necessarily hiding it, which is a good thing to be able to get to that point. And the second point is just one for a little comic relief. There's not too many hearing solutions out there right now that you can have a dramatic effect of putting them on and taking them off.
voila. And what, to Tony's point, what he just showed is something glamorous. It's a lifestyle choice. And are you putting on yours too, Andy? Oh, he had like what I have with the hearing. But one of the things that's happening now is there's a generational distinction between what we are accustomed to hearing related to stigma with older folks to the younger cohort today. Now, you have all kinds of earbuds with nice features built in that will discreetly enhance your hearing, maybe for communication, for noise management, or sound wellness. Now you're starting to see, I am taking care of my hearing without being told. Traditionally, we were told, you need to get a hearing aid, you can't hear. Ugh, that doesn't feel good. That's why you have this resistance. But now you have these cool consumer as well as prescriptive solutions that have a cool factor to what Tony was saying. And you know what? I don't know why it works, but there's something in it that's making me feel and even hear better.
I think there's also something to say about ableism. I think that more and more people are starting to spotlight it, starting to cheer for that underdog and say, oh, everybody that is misrepresented or underrepresented, do you see how significant they are or how much value they can contribute to society? And I tell parents all of the time, it's much harder to acquire a hearing loss than it is to grow up with one. Because when I was learning my life and social skills, that's the challenge that I had presented to me versus going through life, having normal hearing, and all of a sudden, I have to learn these new skills that I've never had to use. I don't have that muscle. So growing up, Bill, Sherry, you and I, like we grew up having to use those skills little bit by little bit in our everyday life versus, oh, I'm a CEO of a company and now I suddenly realize I can't hear something. What do? Give me a device, give me a magic pill, give me something. So I think that we're shifting that view of ableism, the underdog, and being much more adaptive and open-minded about it.
And I think to further your point, Michelle, and what Bill and Tony just said, I think there's something about the psychological impact of treating the hearing loss. And we definitely see it in the Lyric space. because patients aren't reminded every day about the hearing loss. So that tends to add to this confidence and just an increase in their overall well-being, because they don't wake up thinking, I have a hearing loss, I need to put something on, and multiple times to remember to put it on. But I think that overall, as Tony said, that confidence that the hearing care can provide in any solution really speaks to their overall well-being, as well as that psychological benefit too.
And I think confidence, in a way, is the exact opposite of stigma, right? Because confidence is when you feel good about yourself and your ability to walk into a situation and be able to participate in a confident way, versus that stigma of worrying that you're not going to be able to walk into a situation. So I feel like any type of device that's going to give people confidence is going to break down stigma. I don't think it's really hiding the stigma. I think it's actually building that confidence, which is in turn going to break down that stigma. And when you feel that for yourself, when you feel that confidence, you feel less stigmatized. And I think then you're willing to sort of talk about it. It's like, hey, cool, look at my cool new devices, or look at this cool thing, or wow, have you tried this? This helped me so much at the theater. And that's really going to be what I think over time accelerates and breaks down that societal stigma, which hopefully becomes that, virtuous circle. You get more inside. But it really starts, I think, with that building confidence that breaks down that stigma you're feeling.
I think it's interesting you mentioned theater. Go ahead.
I was just going to say that one of the most strange things I'd heard in a long time when we were doing clinical trials on lyric and then with patients thereafter, they would always say, I wear hearing aids, but you can't see them. If you just look way down in my ear, you can see it down in there somewhere. But so people who would be very self-conscious about amplification in general, if they were wearing something else, are walking around showing people just exactly where it is, way down in their ear. In fact, I'm surprised they didn't have them an otoscope so they could show them where it was. But anyway,
I do that sometimes. I definitely do that sometimes.
Oh, I bet so. Yeah, I mean, people do that. But the bottom line is that that I think that those kinds of products, the form of the products is making somewhat of a difference to many people. People who, were high-level executives and didn't want to look like they were losing anything. Those were big candidates for lyric and some products like that. But you'll see the people about the same age on the other side who will actually be an individual who doesn't care, and it doesn't make any difference. And so you've got one side and the other side, and I think the form is helping a lot, because even instruments that do a lot and hook up to a lot of things, they're getting smaller and smaller and smaller over time. So if we were, how can the different stakeholders like clinicians and companies and consumers, how can each of you guys contribute, well, not you guys, but each of those classifications contribute to reshaping the narrative? We've been talking about it a little bit, but maybe we want to kind of hit that issue just a little bit. What can we do as clinicians, consumers, and industry to facilitate the reduction of this issue? And
I'll jump in and just say that there's many answers to this, and we'll hear from this distinguished panel.
you would, because you got the glasses, man.
But there are a lot of other cool solutions that we all can relate to, that we're all part of. It's not just one. But part of it is, whether you're a clinician or you're in a storytelling capacity, it is really the ability to keep also, from a professional perspective, not only consistent messaging, but it's got to be positive messaging. Often we talk about hearing loss, all the things we cannot do, as opposed to changing the script and talking about lifestyle and improvements and enhancements and empowering and confidence. This is the kind of language that we have to move sometimes. The baseline of clinical audiology and solution-based conversation is critical. It adds validation to what is being prescribed or being provided. but there has to be a certain level of enthusiasm that starts from the clinician. And that's where influencers and companies and those that have great messaging that are positive and open the eyes to hearables makes a huge difference.
And I think also it's about setting expectations. Born with a hearing loss or late in life with a hearing, two very different approaches. I mean, we all know about Richard Einhorn, who was a composer and who late in life had a sudden hearing loss, so he's on a mission to find a solution. But we need to be setting the right expectation to whomever, wherever they're at, and what's out there. The key thing is listen to what they have to say. To go in and get a hearing test and hear your audiogram result. Now I've been wearing hearing aids since I'm 6 years old, and it wasn't until in my 50s that I knew that there was a distinction between consonant and vowel. No one ever told me that. But the important thing is, what are you experiencing? Talk to me. What are you going through? Let's find a solution for you. Maybe prescriptive or OTC or some kind of awesome assistive device. And that's what we need to do, is to be able to have a dialogue with that individual. What's going on in your world? Let's talk about it.
I talk a lot about access, inclusivity. It's not that something changed about you, like you as your personality or your being. It's you don't have access to certain sounds that can add to your quality of life now. So when I'm counseling patients, I will say, what is it that's important to you? When Sherry mentioned theater, is that something that really gives you life, that really invigorates your soul? Is it hearing your grandchildren? Is it just hearing, The Price is Right on TV? What is it that gives you so much excitement to get you through the day? How can we get you access to that? It might be a device. It might be some more visual cues or practice from your family. How do I raise that awareness? We're also changing the language around hearing loss. I think, Bill, you mentioned that. I grew up using the words hearing impaired. And now I shifted over to some people I say I have hearing loss. It depends on my audience. I say I'm deaf to people who are hearing. And then I'll say I'm hard of hearing to people who are deaf and use ASL. It's very different in the wording that you're choosing, because how you relate to other people also is a huge reflection on how do you relate to yourself and your own deaf identity.
And we need to keep working on that language too. Matthew Alsop brought this up. Why are we calling it age-related hearing loss? Why don't we just say that your ears wear out over time? And I really like that. I think about, I'm a distance runner, and I can tell you my race times now are a lot slower than they were 20 years ago. And nobody, says that I have age-related speed loss. Why do we have to make that aging tie-in when we have an ageism problem? Why don't we just talk about the fact that our ears get a little bit worn out over time? And then with those positive descriptors you mentioned, Michelle, I can get you access to the theater, or better access to the theater, or better access to the television, and stay away from the labels that feed into the stigma.
And Andrew,
and I think that's a great point. Andrew, I was going to just say, when it comes to the the terminology, I think there's generally a misunderstanding in the spectrum that is hearing loss. I've had plenty of patients that show up with minimal hearing loss, but they say they're deaf. But also when it comes to the common terminology that we used, to your point, Andrew, how we talk about it, but you'll even get patients who've had someone say you have a certain percentage of hearing loss, to the patients who are told they have a mild or a minimal, and so it's really difficult, I think, for the population to know how to break that down or to understand what they need to do about it. Obviously, if I'm told I have a mild hearing loss, is that something I should do something about? Maybe, maybe not. But if I'm the person that's really struggling, to your point, Bill, and just listening to them, maybe that person with the minimal hearing loss does need help because they are struggling significantly in those environments that they're in. But it seems as though we do lack some of this common terminology that helps the general population maybe approach hearing help with a less stigmatic way or with less denial.
And Michelle,
That's really important about just this overall messaging is expectations, right? And that it has to be about more than the device. Because hearing aids, cochlear implants, we all know they're not going to take our hearing back to normal, right? It's not going to fix the entirety of our communication issue. And I think it's really important for people to understand that, because if they don't and they start using any type of device, a professional device, an OTC device, and it doesn't solve their problem, they are going to be disappointed and throw the thing in the drawer and not continue to work at it. But what I think a very important change in messaging from everyone in the industry needs to be that it's technology plus, right? It's all about the attitudes that we hold about our hearing loss, and then also behavioral changes, visual cues, other things that combine with the technology to help us to communicate better. We have to sort of shift that, I guess, focus from hearing better to communicating better, because that's really what we're all looking for from our devices plus.
You know,
and
Sherry,
Sherry,
there's always a point where I walk down to the bookshelf over there and get your book. Don't make me do it now.
Sorry.
I witnessed that before, Andy. I have. So I've seen you go over. One of the things I would like to add to that, Sherry, is taking a moment when you really listen to somebody. I am shocked to learn I don't have a hearing issue. I have a noise issue. And now part of what you were asking, Robert, is where's the stigma? What is the stigma? I think the problem is, okay, I think I have a noise issue and you want me to buy a $4,000 hearing aid? Whoa, something not right here. Give me more. Let's talk about it a little further. So, and like Michelle, what you were saying, what is the lifestyle thing you want to do? That's what we need to be finding. We need to unravel what's going on there to get you on the right direction.
But also know that hearing devices, the most common misconception about them is that they level the playing field. We still will have issues in noise. We still benefit from visual communications, just like closed caption on the TV. We're created for deaf and hard of hearing individuals, not for the hearing people who just want to be able to know the score at the bar. You know.
And I'll just piggyback on what some of you have said regarding expectations. And that is one thing that OTC does bring to the table is a reset on expectations in that early patient journey to open the door for them to recognize that they can use this for situational solutions, you know, on the OTC side, which is hardly ever talked about on the prescriptive side for obvious reasons, right? It's a constant matter of hearing improvement there. But I think that opens the door for early adoption and acceptance when you look at the possibility of looking at this as an entryway for situational opportunities. The other thing I would say, and this might be biased from my position, Buzz, but the integration of the optical world and the hearing world opens up the narrative, opens up the discussion, because now you have got another huge group of professionals in optical that are saying, look, you know, now that hearing aids are available, of course, we're on the glasses side of it, but they're populating the story, the early education of go see a hearing care professional and understanding that, because we all know that as we do get older, it's a matter of fact, both our vision and our hearing decline. So being able to just look at that from a greater scope, a greater scope, and cross-referencing with other healthcare professionals, even GPs at some point, is going to be great for everyone at every part of the patient journey.
That kind of brings us to our next kind of stimulation question here, guys, that has to do with the role of primary care physicians and other gatekeepers. And I might just say about the optometry people or the optical people that that early on they did when a lot of optical shops decided to add hearing aids into their shop. A substantial amount of those went bankrupt because they really did not understand the hearing impaired individual walking in the front door. They kind of worked with them more like they did on the optical side rather than on the other side. Now, I see with our entrance more into some of the optical stuff, it's going to make a difference. So that you might mention something about that. But the big thing now in this discussion would deal with more with what do we do with the physicians and the nurse practitioners and the optical people as well as dentists and everybody else that seem to be semi gatekeepers to maybe change their focus toward some of the things that perplex people that are considering amplification.
And by the way, those gatekeepers really should be defined as door openers.
Oh, well, that's good. That's a sales way to say it, Tony. I understand that. So
I love that. I've been talking to a lot of pediatricians and geriatricians as well. And pediatricians do a lot more screenings for the development of things. How are we doing? How are we growing? How are we, at what rate are we doing this? And they don't do similar types of surveys in geriatrics, which is such a bummer, because as Michelle was saying, somebody could have an audiogram, mild hearing loss, but what she didn't mention is another person could have the exact same threshold, but be completely different in their cognitive ability to process and hear and understand speech. So they need to figure out and work together, I think, with audiologists to figure out where are they in that decline. Is it processing? Is it noise induced? What kind of hearing loss do they have? And identify, go to an audiologist who can do speech perception testing on them, not just threshold testing, because the thresholds really don't tell you that much. I could probably hear more with a moderate to severe hearing loss because I grew up wearing hearing aids and processing it that way, versus somebody who's newly diagnosed with mild to moderate and can't process as surely or confidently.
I have a question for Bob and Michelle, since you are experienced practitioners. How many referrals have you gotten over the years from a general practitioner saying, hey, we believe this person has a hearing challenge, and was referred by the physician?
I've been educating more people.
I used to get a lot of referrals from physicians, Bill. In fact, I had a huge referral source in my city, and they wouldn't really write a letter, but I'd get a lot of little prescription pads and phone calls from and when you first start, and you start at a time when audiology isn't well known, back in the 70s, what happens is that they don't even let audiologists, when you have a hospital appointment, park in the physician's parking lot. But as it turns out, and you get to know those guys, and you take care of some of them in the clinic, as well as take their referrals, and their patients come back and tell them, then you not only get the parking spot, but you get a lot of their referrals back from those individuals. So I had a lot of referrals. So now, Michelle, you can maybe speak to that. Some of the other colleagues here can speak to that as well.
Obviously, I get more pediatric referrals just because of my patient population, but I think that there are more things set in place to catch hearing loss in kids. Preschool teachers are trained in developmental. Regular teachers, pediatricians, optometrists, all of them are kind of interrelated. But when they're talking about adults, it's harder because it is an invisible disability. Someone who has a spouse can lean on their spouse. Hey, can you do this phone call for me? Can you make this appointment for me? But now we have new devices and apps such as InnoCaption that closed captions their apps, but they still have that default, oh, someone else can do that for me. My daughter, my son, my wife will be able to make that appointment for me. I think it has a higher significance of falling through the cracks when we're older.
And also a certain amount of people perceiving hearing loss as causing cognitive decline in older populations too. They automatically assume it's cognitive decline and never even think about hearing.
Or isolation or depression or something like that.
Michelle?
I love those points you make, Michelle, because obviously even after preschool or the younger ages, you still get hearing tests regularly throughout schooling until you graduate at times, right? So like there's this regularity of that does fall off. And I know there's been advancements even in ways to do hearing screenings, and it would be great if people could just start setting their own reminders to just check in and do that once a year in that interim population, if you will. But coming back to the other caregivers as gatekeepers, I think I'm happy that, Bob, you got referrals, and obviously, Michelle, you're getting them from some of the pediatric side, but I don't think it's as common as it should be, kind of probably where you were thinking, Bill. I think we can absolutely get more referrals. We just have to do a lot more education, which is a challenge. It's hard to get time with some of these physicians. Maybe even how do you change the narrative in schooling for them when they're trying to take on so much information that seems much more life and death, if you will, even. So it's a challenge, I think, but I think their perception really impacts it. We know patients trust what their physicians say. So if they brought up anything about ringing or tinnitus in their ears and they're like, yeah, everybody has it, nothing you can do for it, that's a huge disservice to the patient when there is something you could do for it, just the same for hearing loss. So we need to have a way to help those caregivers build their confidence to pass that knowledge on to the patient that, yes, there's something you can do for this and you need to go see this person. But it just doesn't exist as broadly as I think we would all like for it to.
And Michelle, what you said and Andrew said.
Okay. I mean, I agree with that. I have hearing loss, right? My doctors theoretically know this. They have never, other than my audiologist, obviously, has never asked me, how are you doing with your hearing? It was never something that was brought up by a doctor ever in my whole entire life, right? Unless I brought it up. So I think what we really need to hope to do is have physicians make that just a normal part of the conversation. They ask you about what are you eating? They ask about, are you regular in the bathroom? There's a whole host of questions, but they're not asking you, how are you doing communication wise?
And they won't in this country until the U.S. Preventive Services Task Force agrees that that's an important part of the protocol, right? Doctors are very overstretched, and the conclusion when they reviewed it a few years ago, the USPSTF, was that it's not efficacious to address hearing with a pure tone screening test in older populations because it's not an adequate screen and too many people aren't taking action afterwards, and therefore they are not recommending that doctors address hearing loss as part of their normal health checks. And that has to change before overstretched doctors will take it on.
And Andrew, to that point, one of the things that even though hearing may not be the headline, more and more news and education that we hear about, for example, in dementia, takes the lead that allows us to dovetail hearing loss. And so when we start talking in terms of integrated impact on overall health and societal good, that's what we have to utilize and promote even more so, because that helps everyone, education and self-care.
Yeah, a very good reason to drive that change. I agree. And hopefully that will start to take place as a result, the relationship between hearing and dementia.
I think it was an interesting point you made, though, Andrew. It's a little unfortunate if it's being pushed that those physicians need to do the screening, right? Because I think that's adding to their overstretchedness, if you will, where really it's just them being able to refer them on, even if they don't know if they truly have a problem. But if the patient says that they are having an issue, that's when the hearing care professionals need to be treated as the professionals, just as equals to these physicians, to say, that's where you need to go. They're going to be able to assess you, just as the patient that may come to a hearing care professional that may have some cognitive decline. I'm not going to treat it. I know I need to refer, right? So there's that back and forth versus needing to do the full screening. I don't know that has to live there, as long as they're open to having that conversation of, you can have someone help you with this, and this is where you should go.
Yeah, right. Yeah. If the patient is proactive and brings it up, right, then I know cases where local hearing care professionals have forged links with the local doctors to get that sort of referral. So it's not a proactive check of hearing, but if the patient brings it up, they do refer.
Yeah, of mindset, right? It's that
it takes typically 7 years for somebody to realize, oh, I can't hear something and get into the office. I think it's more like 10 to 14 years. But how would you know if you're missing something if you don't hear it? The words are not hanging in midair. Like, if I can't read something, I need to go to an optometrist or an ophthalmologist. The words are not hanging in there in midair for me to reread or rewind to go back to. How would we know?
Bill?
It's a change of mindset, I think, for these physicians is that, that hearing is actually an important part of overall health. It's not an afterthought. It's not something that it should be recommended against. And they don't have to, like Michelle said, they don't have to do the screening themselves. They just have to ask about it as a normal part of somebody's life. Are you having any issues with communication? It doesn't even have to be about hearing specifically. It can be an open-ended question that addresses hearing, it addresses vision, it addresses isolation. It addresses so many things with just one open-ended question. And it really puts that piece of health at the forefront rather than as something over to the side.
And Sherry, to your point, as part of the routine checkup, what do? They check in your ears while they're checking the rest of your sinuses. And what a great moment to say, so, how are your ears? And if the person doesn't respond, that's an indication of something. And repeat it, let's talk about that. So, and I think it's such a natural way to begin that discussion. Not just, do I have impact wax or whatever. And the other thing that also needs to take place is my pediatrician once saw I had something horrible on my eardrum, and it turned out to be a piece of tissue pressing against the eardrum, and the pain was beyond excruciating. So what did he do? He unraveled a paper clip from his files to take it out. Now, I was all better and all that. I was grateful for the pain, but there needs to be some kind of medically responsible approaches to how you address the hearing issue.
As much as people bash OTC hearing aids or maybe Apple AirPods, they have screenings in there. So I applaud that they have a hearing screening built into the software, Apple AirPods and OTC hearing aids. So they can do a hearing test in the comfort of their own home. Now, I would not have my license on that audiogram or threshold test that they take, but at least it's a step in the right direction.
Agreed.
So now, one of the things that wasn't on our list of topics that we should talk about, but I think I'll bring this up because we have consumers, industry, and clinicians all here. Do you think that as audiology moves into a provider status, that things may change somewhat because we'd be seen more as colleagues with our other providers and so on? So anybody have some thoughts on what happens when we become providers? Will that modify this stigma thing just a little more or not?
I hope so. That's what I'm doing online. I'm trying to erase that stigma. I'm trying to show people all of the things and all of the different hats that I wear as an audiologist. I'm a counselor, I'm a mentor, I'm a diagnostician. Like I am a hearing aid fitter, a cochlear implant programmer. But at the very bottom of it, I like what Tony says, I'm a door opener. I am here to provide information and resources so that you can make the best decision for your life or your family dynamic because you actually do know it best. I think there's a shift in physician or provider dynamic that, my parents just heard the physician and they did what the physician said. Now there's more of a shift of, okay, they're giving me some information, but I'm going to be empowered and feel confident in making the choices. Now it's a choice. I don't have to do just what the doctor said. I'm going to get a second opinion, or I'm going to sit on this information for a little bit. I hope it changes. I'm trying to do that.
For anybody who's got kids, I've got a daughter who's 26. I didn't come from a point in my life where I could go onto the internet and self-learn everything from, how to build a cabinet to how to really get a self-diagnosis of what might be going on with me. I think that opens up the door for addressing stigma as well, too, and from a clinical perspective, because now I think that the consumer is much more empowered and self-learned and can work with professionals. And that only populates or stimulates, to use your word earlier, Bob, the ability for people to have this discussion and open that discussion and see the appropriateness of different types of solutions.
I think it also raises quality of care when our community is more empowered and learning on their own, because it's like, well, I heard about, a Verifit machine. Do you have that in your clinic? I would like for you to do that so I can have a little bit more data and feel better about myself.
I agree. I really like when you're talking way at the beginning of this, Michelle, about the hearing loss community. And I think that's one of the changes that has happened too, is just how much more information is more readily out there, even whether it's always correct, but just the engagement with social media as well. But I think because of that educating that patients are doing on their own, it also puts the onus on us as clinicians, for those of us who are, to be well educated. And if the patient, for instance, is coming in asking for an invisible solution, convincing them that a RIC is invincible actually isn't meeting their needs. So are you actually sending them out the door because they knew what they wanted, but you couldn't help them meet that? Or can you help them find really what they want? I always feel like the best solution for any patient is the one that they'll wear. And it may not be the one that's in your book or my book or any book as the most technological advanced or something like that. But if they won't wear it, it's not the best solution for them. So I think hearing truly, kind of to some of Sherry and Bill's points earlier too, hearing truly what the patient's saying or what they're looking for, whether it may totally fit their audiogram or what we think is going to work, may not matter, because if they won't use it, what good is it? And if they walk out the door with nothing, we haven't achieved anything.
And Michelle, point, Bill, real quick, the interesting thing too, obviously I would never call anyone out, and this could be a little controversial and maybe grade some people, and that is, I had a really wonderful conversation about a year and a half ago when OTC was trying to take off, and in a conversation with two very, very phenomenal hearing care professionals, the debate that we had, a playful debate, was, is your scope of practice a prescriptive dispensing practice, or is your scope of practice hearing healthcare, which brings early onset OTC all the way through implant, etc. Because I think that we also have to look at how are our clinicians positioning themselves. And there's nothing wrong if your expertise is solely on prescriptive, but if you back up and look at the entire journey and we look at that mentality, that's where you'll be able to draw in more patients as far as their understanding, their acceptance, and getting going on that journey.
And that really starts with, I think, the way we're educating the students, audiology students, the way they're coming up through their educational system, is that there's so much focus on the device and the programming and the measurement, and not enough focus on the oral rehab and the counseling and asking open-ended questions of your clients so that you can determine what their needs are so that you can better meet those. And I think part of the solution, I think, is really including advocates and other people with hearing loss who are willing to share their experiences and their stories and their expertise as part of these curriculums, whether it's in the classroom or at annual conferences. I mean, there's just so much room for the person with hearing loss to share their expertise with the industry. And it's nice that it's becoming more typical, but I think that there's a lot of room for additional sharing in that regard.
I precept audiology graduate students, and it's so, I precept audiology graduate students, and I tell them, you know what, your appointment starts the second that their name comes out of your mouth, and you are starting a potential lifelong relationship with them. So you get to know them as a person, get to know what ticks, what talks, what bothers them, what is it that fulfills them, get to know them as a person, not as a number, not as their audiogram. And I'm trying to shift that over to hearing healthcare provider versus somebody like, maybe you'll see them one time, because that most of the time is not the case.
Yeah, and I do want to add that back in the day when MFI, made for iPhone hearing aid, was introduced, I was shocked by the stubbornness of audiologists saying, well, it's not my job to be connecting hearing aid to your iPhone. I don't go near iPhone. It's like, whoa, this is a great enhancement. This is the best thing since sliced white bread. Come on. This is a lifestyle thing that you're providing. Come on, you're in the hearing healthcare business. Don't be stubborn. You're almost like a horseshoe. You're hard to bend. I'm trying to get you to bend and see otherwise. And each time we introduce a new technology or a different concept, oh, this was just we don't, oh no, we come from this old school. This is how we do things. We don't like change.
Let's hope most
Evolve.
of
You
those
have
old
to
school.
evolve.
Let's hope most of those old school people are moving on, Bill. Now we really it's kind of time for us to close up our discussion, as we've had a very lively discussion on this topic and listen to a lot of points of view. We've had a whole lot of orientation. Right before as we close, does anybody have just a short comment about the future, and then we'll begin to wind down our session?
I do, Bob.
Okay.
No more excuses when it comes to stigma. Hearing technology today and what's available to us has never been greater than ever before.
Okay.
I'll keep it short as well. I'm going to continue that thought. Just a general concept as we look at the future, through the perspective of, let's say, OTC, that early onset. Not only does the consumer need to have access to cool innovation and confidence, but the same applies to those professionals that are working it. So moving away from, well, just try this, to this is a solution for you. And that enthusiasm and confidence behind it is critically important for a patient as well to hear and experience.
So with that, I think we will wrap up our session. And I want to thank our panel for being with us today: Michelle Webke, Bill Schiffmiller, Michelle Wu, Sherry Eberts, Andrew Bellavita, and Tony Solsona. Thanks so much for being with us today here at the Future of Hearing Healthcare. And yeah, you had to just put your glasses on right there, Tony. Anyway, so thanks for being with us at Future of Hearing Healthcare today, and we'll see you around the conference.
Thank you, Bob. Thanks, everyone.
Thanks, Bob, and everyone.
Thank you.
Thank you.